Hello and welcome to CVC. Today I am going to talk about below-knee interventions. As we know, due to the increasing prevalence of diabetes mellitus, the below-knee diseases are becoming more and more common, and the management of below-knee diseases is also becoming better and better. So that's why we'll see that how below-knee diseases are being managed. So goals of treatment in a below-knee disease is to improve wound healing, because most of these patients usually present with a non-healing ulcer or with intractable symptoms like pain at rest. Then another aim is to go for a limb salvage, then to improve the functional capacity, because many of these patients actually present with symptom limiting functional capacity with intermittent claudication. However, there are a few basics of a procedural steps, like we have to understand the arterial access. For a below-knee interventions, we usually need to go for an antegrade puncture. Then there may be need for a retrograde puncture. Then procedural imaging is very important. We should treat below-knee diseases like coronary. We should take multiple views in LAO, RAO, sometimes caudal, cranial, to understand the angulations, to understand the disease. Then we should have a clear understanding of the anatomy. Sometimes the angiosome concept is used because it is hypothesized that many of these arteries actually may behave according to the angiosomal distribution. However, this is controversial. Some publications have also questioned the angiosome concept, but that's okay. We need to understand the anatomy. Intraluminal approach is the best. However, if intraluminal approach is not possible, then we need to go subintimal. Many of the times, below-knee diseases are actually long lesions. So long lesions are sometimes very difficult to cross from true lumen to true lumen. And in such cases, we need to go for a subintimal approach and then re-enter into the true lumen. Then re-entry devices, sometimes dedicated re-entry devices are also important. Then we have to combine antegrade and retrograde approach in some of the cases. So this is the angiosome concept. I think this is a very old concept. Everybody is aware of this. I'm going to discuss this presentation through presentation of few cases. So here is a case of around 65-year-old male who presented with severe pain at rest. Basically, patient initially had history of intermittent claudication for around 1 year, then worsening symptoms, and now the symptoms are present even at rest. And there was a non-healing ulcer on the dorsum of the foot for around 1 month. CT angio as part of the evaluation showed SFA was completely occluded with collateral formation. The intertibial artery was occluded. The posterior tibial artery, there was a long segment disease. The tibio-peroneal was occluded. However, there was distal reformation of the posterior tibial artery. However, we do not see much vascularity in the intertibial artery distribution. And the non-healing ulcer was also in the dorsum of the foot. So first, we treated the SFA disease. We implanted a supera stent, and then we wait for our target vessel was intertibial artery in this case. However, as we see that the lesion in the intertibial artery is a very long lesion. So here, I actually used a novel method. I took a crossverse microcatheter. Crossverse microcatheter is a type of special microcatheter that is used for coronary CTOs. So this microcatheter can be advanced even without a wire by rapid torquing. So in this case, I took the crossverse microcatheter and advanced the microcatheter through the intertibial artery, and this also entered into the true lumen distally. So there was a long subintimal tract, but we could establish a distal true lumen re-entry. So this is the injection through the microcatheter, and we see that there is a disease involving the dorsalis pedis. So this is the selective injection revealing the disease. So through the microcatheter, we did wiring of the dorsal arch by using a command wire. So this is the wiring of the distal arch. And then balloon angioplasty was done with long balloons, 2.5 into 150. And then we also did some modification, reconstruction of the dorsal arch. So this is the below the ankle angioplasty. And as you see that the final result, we did not touch the posterior tibial, but we see a good flow restored in the intertibial artery. I'll just show. Yeah, so good flow up to the digital vessels we can see. And this procedure actually helped the patient, and there was with with the help of our plastic surgery colleagues and with the help of our wound care specialists, so this wound could be resolved and the patient improved symptomatically after these peripheral interventions. So this case highlights and some of the challenges in a below knee intervention, like long lesions, multiple diseases. What we have seen is that multiple arteries are involved in around 90% of these cases. All these diabetic patients, they have involvement of multiple arteries, anterior tibial, tibioperoneal, posterior tibial. So many arteries will be involved simultaneously. And in this case, actually, I choose to intervene in the anterior tibial artery because all the arteries are diffusely diseased. All the arteries have some collateral flow, except the anterior tibial artery was not much collateralized. However, the non-healing ulcer was in the angiosome distribution of the anterior tibial artery, so that was a target vessel. Rest of the vessels we did not try to intervene because there were collateral flow, there was distal reformation. So, and the patient also improved after this case, after this procedure. Then I would like to highlight another point. So this is a 56-year-old male. However, he is a chronic diabetic for around 10 to 15 years and presented with complaints of intermittent claudication for around 6 months. That has progressively worsened with pain at rest for around 1 month. So CT angio showed there was occlusion of the popliteal artery and there was a disease in intertibial, the peroneal and posterior tibial. So like as we have been discussing, that most of the time multiple arteries are involved. So in this case, what we did was there was a distal reformation of the posterior tibial artery and the tibioperoneal trunk, and there was a collateral supplying the intertibial, reconstructing the intertibial artery. So in this case, what we did is we went through transcollateral retrograde approach we did, and then we crossed through the microcatheter and came back to the proximal part of the intertibial artery. So there was a CTO in the intertibial artery ostium, and then proximal intertibial artery CTO was intervened, balloon angioplasty was done, and then we did kissing in angioplasty, and this is the final result. So this case, again, another technique that has been used is the transcollateral angioplasty. Transcollateral angioplasty is an important technique in many of these peripheral interventions. So crossing strategies in such cases can be antegrade strategy, that is endoluminal or subintimal, or it can be retrograde strategy like a pedal plantar loop or transcollateral, or it can be retrograde access, direct pedal puncture and retrograde access we can do. So in conclusion, in patients with CLI or below knee disease, the key to a successful BTK interventions are choice of vascular approach. So we have to choose whether to go for a antegrade approach with an antegrade femoral artery puncture or retrograde approach. Choice of materials, hardware is very important. Knowledge of all the available techniques is important. And stenting should be considered only as a bailout situation. The clinical outcomes depend on a proper infection control. However, success of the endovascular procedure is of paramount importance. Thank you.